Hi all. Thanks, Jordan. Hi, John. Would you like to start with an update? Is that okay?
As you asked so nicely, Alex, thank you very much. Joined with by Sarah Furley today from the executive team, who's our Director of Partnerships. Welcome, Sarah. So, yeah, where are we? A quick sort of 5 minutes run through some of the headlines. Overall, I think things continue to move in positive direction. There's an awful lot going on, but the heat of the pandemic particularly is clearly passing, isn't it, in terms of number of new cases, number of admissions to hospital, the push to discharge. However, I think it's worth emphasising that there'll be clearly a differential across different teams, different directorates, different divisions in the organisation. So, for example, those of you that are working in mental health and adult mental health, particularly at the moment, will be really feeling the heat in terms of both the acuity demands of people being admitted and being unwell, but also there's some of the really acute staffing problems. And we were talking with Julie at Field early this morning. Her sense is that this is the most challenged that directorate has been during the pandemic. So organisationally, we just need to be aware of that it won't be just a smooth trajectory down for everybody in nice order, and we're going to get hotspots and challenges to continue to manage. So that's just to recognise that. More broadly, in terms of outbreaks, we're at the lowest number, I think, since way before Christmas, down at 4 at the last count. No, and they've all been in play for some time. It takes up to 28 days to close them down. So you remember we were up at 13, 14 at the peak. So that's, again, really good news. Sarah will say a bit more about the vaccination programme a bit later, but broadly speaking, we are continuing to vaccinate our patients across the different services. Just heard this morning that Rampton's first doses have been completed, which is really good news, and we're continuing to coordinate how we make sure that people with severe mental illness and other related problems get access to their first dose in the coming weeks. And it's a bit of a logistics challenge, as you can imagine, coordinating that, but already there's some pleasing uptake and coverage. Within our staff groups, I can't remember the exact percentage, Sarah, others might do, but we've done a really good job. I think it's about 78% of staff have now received first dose, and again, good coverage through all the different geographies and services. So that's a really good position to be in. There's a question a bit later on about an update on the position of where the organisation is in terms of those that either haven't had it or don't want it, and we'll come on to that in a bit more detail a bit later. The headline being is it's not mandated, we're using a values-based approach to make sure people can make an informed decision as possible. And then, as I think sort of indicated last week, we're going to start to introduce conversations about other things other than COVID and the vaccine, which has dominated all our lives for, well, I think literally a year this week, isn't it, that it's since the first lockdown. But other things will now come online quite quickly. We've got to make sure that we support all our staff to make that transition, but also find time to recuperate and recover, and that's going to be really important to do that. So although I get told off for this, and I have flagged the fact that the staff survey headlines are good for us. We're actually be allowed to talk about it from tomorrow because the embargo is being taken off, and there's going to be a national release of national staff survey scores. At the moment, what we know is compared to the other organisations that use the analytics company that about half the NHS uses, called Picker, and we know where we are in relation to those. So tomorrow morning will be new news for us too. But again, we're optimistic. The headline being is that we're probably one of the most improved mental health and disability community organisations. It's been our best set of results for over 5 years. And in terms of there are 10 key domains that you get a summary score on. We've improved significantly across the board in 9 of them, and it's not just a little bit of a percent. These are significant improvements, which is fantastic news. That all the staff that have been involved in all the work to support that is phenomenal. To be able to turn a big tanker like this organisation around is brilliant. I'm really pleased for everybody across all of the organisation to get us to that position. So it's a big thank you from me. It's a big thank you from the executive team and the board, and we need to recognise that. It's fantastic, and it's worth taking a bit of time to celebrate it. And again, to be clear though that the job isn't done. There's still lots of work to do across all those domains, whether we're talking EDI, whether we're talking morale, whether we're talking safety cultures. And because although those scores are good, it takes us, compared to others, into the pack, into average. That indicates how challenged we've been over the last few years. But we started that process of recovery, and it's grounded in, I think, really embedded improvements. So it sets us up in good stead for the times ahead. In the other things that will be coming down the line fairly quickly at the very more traditional sort of annual planning round, finding out what our financial envelope is going to be for 21-22, and having to fill in a squillion templates to tell everybody what we're doing with the finance, what we're doing with the strategy, what we're doing with the outputs. So there'll be a lot of people involved in teasing that out in short order. And very quickly the NHS will get back into, despite some of the rhetoric, get back into the challenges that stacked up over the last year, particularly in acute care, in people in waiting times, access to cancer care and things like that, and will be no different, other than we don't have that simple divide between urgent and elective. So lots of, it's a fairly obvious thing to say, but lots of stacked up demand, people presenting with greater levels of acuity, and also an unknown component to that. That some of the national figures on children and young people prevalence rates of psychological problems are really concerning, and the national teams are very worried about how that's going to be seen and how those people are going to be seen and helped. But we need to be prepared, and we need to make sure that we are as accessible, and we signpost and we support all of that as it comes through our doors, as it were. So that's probably enough from me, Alex, to start with, by way of introduction. And I don't know, shall we go directly to questions? Because I know there's some vaccine questions on the list that then Sarah can come and talk about more specifically. Thanks.
Yeah, absolutely. And just to say to everybody on the call, please do put your questions in the chat. Mark Howells has already, and we'll come to that in a minute, Mark. But thank you. The first question, John, and linked to schools as well, is why are schools being asked to do lateral flow testing with nose and throat swabs and not healthcare only do nose?
Yeah, it's a good question, that, isn't it? And you think, oh, well, that's an easy answer, but we don't know. So we're following the national guidance on. I often talk about this. We're in a situation where we're doing as we're told, and there's a whole load of instructions that come down from various august bodies. And in terms of how we carry out lateral flow, that's the instruction that we follow. Why it's different for schools, and I don't think it's different for every school. I think there's different methods being used. So I don't know the answer to that, but we are endeavouring to get some clarity on it.
Thanks ever so much. And as you intimated earlier as well, John, what are we doing about those staff who have not so far had their vaccines and do not want to have their vaccines?
Yeah, thanks. This is an evolving issue. I don't know if people are aware, in the middle of last week, again, we received an instruction that all NHS organisations should essentially track down every member of frontline staff who hasn't had a vaccine, make sure they're offered one, and then have a one-to-one meeting with their line manager and have a recording of the reasons why they weren't having it, without actually going quite so far to say it's mandated. So that's a week ago. Since then, that national line has softened a little bit, but because as people can imagine, it caused quite a stir, really, and it went against some of the sort of more values-based approaches that many organisations were using, and that's certainly our take and perspective on this is that it's not mandated. It's really important that people make an informed decision. We think it's the right thing to do to get a vaccine. We'll supply as much information as possible, given that it's a new and evolving intervention. We'll create spaces where people feel able to answer questions and to provide as much information and assurance as we can that it's a good thing to do, that it's safe and it's effective. And if at the end of the day people choose not to have the vaccine, then that's the case. There is another angle to this, that in terms of an individual basis, that from a confidentiality perspective, we shouldn't and don't know individuals' vaccine status. So we may know, for example, that the uptake in one site or a number of teams is, or in some vulnerable groups is lower. So we know, don't we, that the uptake, there's been a delay in the uptake in some of the BME groups, and therefore we've done a lot of work and trying to encourage and focus on increasing the rates there. But there's been quite a lot of pushback nationally from organisations saying, actually, this isn't right. We're sticking to the values-based approach, and we're encouraging people to do it. So does that sort of cover it, do you think?
Yeah, absolutely. Thanks, John. I'm going to stick with the questions around the vaccine, and then we can head to other things after that. So I don't know if Sarah wants to come in on this with regards to the current issue with the vaccine supply and what's happening with that.
Yeah, thanks, Alex, and hi everybody. So we have got what we're calling a sort of temporary lull in the vaccine supply at the moment. It was expected. It is going to continue probably to mid to latter part of next week, and this is as a system. Now, even though I'm saying it's a temporary lull, just to put it into context, we are actually still getting over 20,000 vaccines into the system this week. So we're saying it's a temporary lull, but it's still large volumes are coming in. So what we're doing is this week we have reduced the opening hours of some of the local vaccination centres, but Mansfield, the old Wicks site, which is our big mass vax site, is open. It's still open for 12 hours a day. That continues. But our real focus this week is with GP practices, and the GPs are focusing in on the real vulnerable members of our society. So they're vaccinating this week, the homeless, those living in deprivation, those suffering with various different inequalities, and they're also just doing the last of the vaccinations for those people that are housebound. So that's where that 20,000 vaccines going this week. Week beginning the 22nd of March, so sort of 10, 12 days away, we're expecting a significant increase in the volume of vaccine. That's right across the country, in our region, and therefore in our system. And from that week, we're expecting somewhere between 40 to 80,000 vaccines a week from the end of March, going right into April and beyond. So a real increase in volume. And Alex, what I'm going to do is I'm just going to pick up some other vaccine issues as well while I've started. I'll keep going until somebody shuts me up. I just wanted to talk about uptake as well, because we just touched on it then in terms of our staff. Because you hear all sorts of different percentages quoted, don't you? So from an uptake point of view, we talk about we've vaccinated about 80% of our staff, and that depends on whether you're looking at just frontline staff, whether you're looking at our staff employed on substantive contracts, or whether you're looking at adding in all our bank staff as well. So that's why the figure changes if you hear different figures quoted. Just to add on about those people that are perhaps hesitant or who have actually declined the vaccine. From a population point of view, we are now starting to measure how many people have actively declined the vaccine. And that's actually, for the older population, much lower, I think, than any of us anticipated. And you've seen some of those figures in the media. So, for instance, those people over 80, actually, it's only a 2 to 3% decline rate. And I think as we get through the various different cohorts of our population, it'll become clearer whether that hesitancy or decline rate changes depending on age groups. I think we're all anticipating that it will do. And then the other thing that I was just going to talk about is second doses. And there's a couple of things on second doses. The first thing is that, as John was saying, we've started vaccinating our inpatients, and we've just agreeing this week how to make certain that our inpatients, who we may actually discharge before their second dose, to make sure the process is right, so we follow up and people get that second dose. Now, there are some staff that have been vaccinated in the workplace because we haven't wanted vaccine. So that second dose process will also include those staff that have had a vaccination actually at work. So once we've agreed that this week, we'll share that process with you. I think there's also some concern about staff that have had their second appointment moved. Now this what happened, if you cast your mind back, nationally we were instructed to move to this 12-week period. Now, at the time, we booked some people in at 10 weeks, so that's 70 days. And we were instructed to move people. So there is just a small window of 3 weeks where some staff got booked in at 70 days at 10 weeks, and we're moving those people to 77 days, which is the 11 to 12 week period. If you're a member of staff that is happening to, you will get a letter, and it'll come in about 8 days before your appointment, and you'll get a text message as well to remind you. So that is happening at the moment, and we'll get some comms out about that. And then the final thing I was going to say about vaccines is I'm quite frequently asked about if you've had one particular vaccine, should your second dose be the same drug? So if you've had the AstraZeneca, should you have AstraZeneca, or could you have Pfizer? And the answer is, at the moment, you will be getting the same drug that you had for your first dose. So if you had AstraZeneca, you'll have AstraZeneca for your second dose, and if you had Pfizer for your first dose, you'll have Pfizer for your second dose. So Alex, I'm going to stop there because I could go on forever about vaccines.
No, that's absolutely great. Thank you ever so much, Sarah. John, we've had one further question sent in around vaccines, and I didn't know if you wanted to talk it through, because if I'm entirely honest, I don't quite understand all of the detail of the question.
Yeah, thanks. So this was a question that probably goes to about a page and a half of both statements and question relating to the vaccine, some very detailed commentary on, do you remember we talked previously about the test cycle thresholds for PCRs? Talks about the foundation virological precept of naturally acquired immunity, T cells functioning as opposed to antibodies. My view is, whilst within the question there are one or two bits that I can pick out, I think it's far too detailed for a general session like this, and some of the technicalities and complexities I couldn't address, so I'm not going to pick it all up. There is one piece that I will answer though, which is it says, will the trust be liable for any adverse side effects experienced by staff that it potentially forces to get vaccinated against their will? If you make it a condition of employment, one would assume the liability lies with the trust. So it just gives you sort of a flavour of it. So as I've said earlier, we won't be forcing anybody to have the vaccination against their will. It wouldn't be the right thing to do. In terms of whether it becomes a condition of employment, again, that won't be a decision that we would take. That will be a nationally mandated decision if it comes to that. And I think at the moment, if I was to put money on it, I don't think it will become mandated to be a condition of employment, but you never know. In terms of more generally liabilities, liabilities for things like this are covered with essentially what's an insurance scheme for the NHS called CNST. I can't remember exactly what it stands for, but basically we pay a premium based on our relative risks that covers our liabilities for things like that, and that would depend. So, for example, trusts that provide maternity services, because of the potential risks of delivery and related issues, their premiums are much higher. But it will also depend on, for example, your recent history of serious incidents where people have been injured or such like. So it's quite a complex area, but the trust doesn't bear the direct liability, if you like. I just wonder if there's anything else specifically. There's the comment about fast tracking a vaccine by definition. There is no data on long-term safety. So the JVCI and others concluded that the approval of the vaccines had not been fast tracked. They changed protocols so that they could do work in parallel. So whilst waiting, ordinarily it takes much longer because you get to a certain stage of the trials that you then wait for approval to go on to the next stage. Whereas for the vaccines, they've gone on to the next stage and pending the approval to have occurred. So it cut the time down quite significantly for approval. But the statement is correct about long-term safety. There isn't any long-term data on safety because they've not been around for long. There are differences between the different types. So the modality that the AstraZeneca Oxford one uses is a virus platform that has been around for some time, and there are some longer-term data and research evidence on the relative safety of that one. The Pfizer mechanism is a different sort of virus and is new. There are some very well-developed reporting mechanisms for side effects. No medication or intervention is without some form of potential side effect or harm, and nobody's claiming that they're without problems, but relatively speaking, they're very safe and very effective. I think that's probably as much as I'd want to pick out from that. As I said, long question. Thanks, Alex.
Okay, thank you so much, John. And just to highlight that Anne-Maria has put in the chat that CNST stands for Clinical Negligence Scheme Trusts, and welcome Anne-Maria to the meeting. So thank you very, very much. Just moving to Mark Howell's question that he's put in the chat. We are seeing a number of senior posts shared with Sherwood Forest hospitals. Is there an ambition to centralise functions between the two?
Hi, Mark. Yeah, good question. So there's an ambition to develop our collective expertise to look at areas where we can work together, where we can integrate for the benefit of patients and staff. So myself and my oppo at Sherwood Forest, Richard Mitchell, get on well. We've got a very similar values base, and the outputs of what we do is different obviously in a healthcare context. It's Sherwood Forest is a very good, relatively small district general hospital. We've got a number of services that work out of there or out of the site, and we've both got really clear ambition as to where we want the organisations to get to in terms of, like I say, experience of patients and staff that work in them. We trialled a couple of executive posts across the two that came up opportunistically, really. So Claire Teeney's executive post for people and culture, she works to both boards in both organisations in a combined post, and is looking to see how those teams can work across the both two. And the vaccination programme has been a really good example of that there are a number of people in both trusts working together to coordinate and run the programme. And we've also been looking at a director of corporate affairs to essentially run both the corporate offices as one office across 2 trusts, and that's been going really positively as well, with the same sort of outputs, obviously in a different context. And there are more opportunities to do this. The reason, the other reason that we're doing it is as the integrated care system develops nationally. There was a white paper that people may have seen a few weeks ago that really set the direction for the NHS. The ICSs will become much more of a thing. They'll be described, they'll be put into law, they'll be able to take on more functions. And one of the priorities of ICSs is to develop integrated care and integrated care providers and provider collaboratives, so different organisations working much more closely together. There is a proposal, the premise being that there is certain aspects where there are a number of efficiencies that can be made in terms of, I don't like the term, but back office, that I think is a bit of a sweeping generalisation, but I think there are always ways to improve efficiency and quality of things that we do, and this is something that we're looking to continue to pull together. I think it's important at this point to say that that there isn't a direction of travel where this leads to merger, and this isn't a sort of backdoor programme to get to that. Again, Richard and myself are very clear, as are both chairs, that this isn't on the path to that. It's getting the best out of both organisations working together where we can.
Thank you, John. Sarah's got a hand up. Thank you, Sarah.
Thanks. I found myself over the last probably 10 years working increasingly in system jobs, and certainly, you know, my job today and my portfolio, you know, about partnerships is about getting out there, and sometimes you hear people say, you know, what hat am I wearing today? And whether you're a professional, you know, nurse, allied health professional, doctor, and working perhaps in a management role, you know, you're sometimes answering with your clinical hat on, aren't you? But you're answering with your managerial leadership hat on. And I think when we start to work in these jobs, as we start to work and focus on patients and patient pathways, and I start to work on across the system, I'm asking myself, from a patient's perspective, what's the best thing, but also from an organisational point of view, what's the consequence to my organisation and other organisations, and what's the opportunities and the risks to my organisation and other organisations. And there's something I think about, as we work more together, some of that duplicates, and that has got only, you know, there's only got to be a strength, hasn't there, in being able to stand in other people's shoes, and look at what we're doing from these various different perspectives, so that we get the right outcome. So I guess it's just the flip side of what John's saying in terms of the practicalities of doing these sort of joint type of roles, and holding on to the benefit for patients, because the benefit, it doesn't matter which organisation you're in, it's the benefit for the patient. But actually, if we can be really cognizant of the impact on every organisation, that will help us move forward. Thanks, Alex.
That's great. Thank you so much, Sarah. Moving on to a question that has been sent in. What are your thoughts on the 1% pay rise?
Right. What a good. Yes, I'll start off on that. A great question. And I think the first thing to say is that we're in the part of the process here, aren't we? That this has been the Department of Health has made the recommendation. And the government submitted that to the pay review body we await the outcome. And I think it's a really difficult one. And as with many things in life, I think it's important to have a balanced view on it. On the one hand, you'll have heard me regularly on here say a massive thank you to all the NHS staff that have gone so far above and beyond, not just in the last year, but of, to make sure that we continue to provide the great services. And we know and recognise sacrifices that people have made. So from that perspective, it seems a bit of a kick in the teeth. However, the balance to the argument is that some of the terms and conditions working in the NHS are deemed to be pretty good. I think that's right. There are many people that have really suffered through the pandemic and have no work. Unemployment's going up, and are really on the breadline. The country is facing one of the biggest sort of financial holes in living memory, and so from that perspective, 1% seems reasonable in the whole circumstances of things. I think we'll have to see what the final outcome is. But I think it's. I think my view would be that I think we've got to take a balanced approach on it, Alex, and see how the news plays out on it.
Thank you very much. Thank you. We've got around 8 minutes left in the meeting. Sorry, somebody's got their hand up. Sorry, I'll just double check who that is.
Anne-Maria's got her hand up.
Thank you, Anne-Maria, if you want to come in.
No, I was just going to add about the 1%. I was just to say that nationally, of course, I'm connected into the chief nurses nationally, and the big conversation last week, at the end of last week, was around the fact that they feel that the Royal College's 12.5% ask is a little bit on the high side, to say the least. But what they are saying is that they just want it to be commensurate with what the doctors are getting. So we're not asking for anything different as chief nurses nationally, but what they are saying is that they would like it to be the same as what doctors are getting. So they don't want anything different. I just wanted to add that.
That's great. Thank you. That's really, really important. Thank you very much. We've got 2 further questions. So what is happening at Bassetlaw with changes to B1 and B2? John, do you want to take that to start with?
Yeah, I'm probably not going to be able to do it justice in that time, Alex, given that there's other questions too. But very briefly, the NHS Bassetlaw CCG are looking to develop a number of community services that we're involved with up in that part of the world, and there is currently a consultation engagement exercise that people can. It's important that we signpost people to have their say in those proposals, and there's also a range of updates and commentary on what the plans are. In brief summary, people will be aware that we're in the process of purchasing Sherwood Oaks Hospital just outside Mansfield, where wards will come from Millbrook unit, and the inpatient services from B1 and B2 in Bassetlaw will become inpatient services in that facility at Sherwood Oaks. So the inpatient provision will close in Bassetlaw District General Hospital is the proposal. A couple of things to say about that. One is that the majority of people that are inpatients in Bassetlaw come from outside of the Bassetlaw area, but that doesn't get away from the fact that if the proposal goes through, that people from Bassetlaw that currently use those services, if they need an inpatient admission, will need to go to the new unit at Sherwood Oaks. However, there is a significant investment into the community provision. I'll read the list off just to give people a sense of how wide that scope is. So additional investment in home treatment teams for MESOP services 24/7, peer support workers, crisis services now becoming 24/7, A&E mental health liaison, early intervention and psychosis, individual placement and support for securing employment, perinatal services, children and young people, again with a 24/7 crisis input, and for ADHD and ASD, as well as physical health care. And that in total, that's about a £3 million additional investment over 3 years, and will create roughly between 45 and 50 new posts. So there's an expectation that or a real drive to manage people as much as possible without the need to go to be admitted. And obviously that's not going to work for everybody. Julie Atfield and her team are also working up quite a detailed transport proposal to make sure that we can support families and carers for people that do get admitted, because the public transport is not sufficient. So that's a very brief summary. There's more through that, the CCG, and I think probably through our Connect intranet site as well.
That's great. Thank you ever so much, John. As Yolanda's put in the chat, there is info on our website and that of the CCG, and then there's links to be able to give your views as well. So that's fantastic. Thanks, Yolanda. Just for the records, John, I don't wish to bring this up again, but just for anybody that's seen the chat and is unsure of this, Mark Howes has put, thank you, John. And the new camera angle confirms it isn't a cardigan, which has been a debate in many a Q&A about the jumper that you're wearing. So and there's one final question that's been put in the chat from Catherine Concha, and that's linked to International Women's Day, which and the question is, which woman has inspired or influenced you most and why? John, do you want to answer that?
Yeah, I saw that coming early, and I've been thinking throughout the session as to what the answer to that might be. I don't know. There's so many. Just bear with me 1 second. Right. So I'm going to start by saying two women in my career in medicine have inspired me and stay with me. So one of them nobody will know is a cardiologist called Margaret Simmons, who was my first consultant that I ever worked for as a junior houseman in 1986. Completely clueless. I was completely clueless. She was an esteemed cardiologist, very much of the old school, used to frighten the death out of everybody, including her junior doctors and including the patients. So in lots of ways, she wasn't a good role model, but she taught me particularly how to be a decent doctor and the fundamental importance of doing the right thing for patients. She would have not one iota of issue. She'd take everybody to task all the time, but it was always about why you hadn't done something right for patients, and it always stuck with me. And despite the fact that she was probably one of the most challenging people to work for ever. One of the most inspiring psychiatrists I ever worked for through all my training is a person that some of you may know, Dr. Margaret Oates, who really inspired me to continue to stay in psychiatry and again bring that patient perspective to everything. She was one of the most amazing clinicians that I'd ever worked with. Her ability to be with a whole range of different patients in different situations was just amazing. And then the final one, I'm a bit of a sciencey geek, and in growing up and reading various things, Marie Curie, I think until recent times, the only female winner of the Science Nobel Prize jointly, but well, not jointly, separately, for physics and chemistry, for discovering not one but two elements. And the fact that sticks in my mind was that her notebooks are kept in one of the French museums, and they're still locked in lead-lined cabinets because they're still so radioactive. So that's the sacrifice she made, and her endeavour and perseverance in a very male-dominated world was quite phenomenal and inspiring. That's my off the top of my head list. So over to you two. I can see on my screen, Sarah and Anne-Maria.
Shall I go next?
Sarah's been spotlighted. Yes, please.
Yeah. So, if I'm absolutely honest, this is the first year that I've really stopped and thought about International Women's Day, and I went a bit closer to home because, and I think it was because of the nature of how unusual this year has been. And I've got three friends, and one of them has been bereaved this year through COVID, and she shared that experience and was really vulnerable. Another friend has lived with a long-term condition, and she's shown huge dignity this year. And I had a third friend who she's one of those ladies that is at nothing rocks her. She's steady as a rock, and right the way through COVID she's been exactly the same. And I thought about those three people and what they've meant to me this year in particular, and I think about them as really strong women. And so for me, those are the three people this year, and I guess it's just because it's been such a weird year. I just wanted to think a bit closer to home. So those are my three women. But ask me the question next year, and I suspect it might be it'll be a different answer. Anne-Maria.
I think this is one of probably the hardest questions anybody's posed to us so far. It was easier to come up with a Christmas song list. I've got this is a bit off the hoof. I'd like to have had more time to think about it because I am inspired by a lot of people, in fact. And I'm often inspired by people who've done really kind of like amazing things in the against adversity. So I tend to be very inspired by that. So often if you hear motivational speakers, and one of the motivational speakers I got the chance to listen to was Jo Malone, who does the perfume, and she was amazing. She fought breast cancer. She made all of those soaps in her kitchen. The things that she did against adversity, and I tend to be very inspired, both men and women, if they've gone up against things. But I suppose what I wanted to share with you is my mum. My mum, I was a dreadful teenager to my mum. I was horrible to her, but it wasn't until I had my own child that I really felt I understood my mum. My mum didn't speak a word of English when she came to this country, not a word. And she managed to get herself 2 jobs and then 3 jobs. And when we counted up the jobs that she'd had by the time she'd been here for the first 5 years, like 19 jobs. And also she was a child in Second World War, so she saw things that she never talked to us about. And it wasn't until I talked to her brother that I found out what she'd seen and what she'd witnessed. And 2 of her aunties died at Auschwitz. Again, I didn't know these things. And so I feel that there's things that my mum did that and saw and witnessed, but she just never stopped. She carried on working. She had a kid. She just always was there, and she carried on doing stuff. She went into sport, and she just was really good at being there. But she's her brother. She talks about her brother. Sometimes he had a cap on his head, and he's got a bullet through it. That because they were shot at when they saw the bodies being taken along in a cart. and so they hid down in a little ditch so that they couldn't be found, and also like just what they had to eat. They had nothing to eat, you know, in those terrible times. But she never ever kind of like held us against us, or she never ever said, you know, well, in my day, you know, this is what we had to do. She just never did any of those things. So yes, I suppose my mum and Jo Malone.
Wow, that's really powerful, Anne-Maria. Thank you. But we've gone over time. But is there anything that anybody wishes to say quickly before we draw the meeting to a close?
I just round it off then, Alex, to say thank you for organising it. Thank you for everyone's contributions, your time and your inputs and your questions, and for what you're doing. We're making progress. Have a good afternoon, everybody.
Thank you.